Thank you, and welcome to this meeting of the Essex Integrated Care Board. Welcome to members of the public who've joined us here, and also those who are viewing this online. A respectful reminder to members of the public that this is a meeting which is held in public. It's not a public meeting. Could we begin, please, by members around the table introducing themselves? Alex, could we start with you and go around?
Thank you. Alex Green, Deputy Chief Executive and Chief Operating Officer at Essex Partnership Trust.
Paul Scott, Chief Executive at Essex Partnership.
Could you pull your microphone a bit towards you, then we can benefit from your...
Tom Lafferty, Chief Executive at Princess Alexandra Hospital in Harlow.
Samantha Goldberg, Executive Director of Commissioning for Adult Acute Mental Health Services at ICB Essex.
Michael Watson, Executive Director for Corporate Services for the Essex ICB.
Natalie Hammond, Director of Nursing at Essex ICB, and here in replace of Giles Thorpe, who gives his apologies.
Dr. Matt Sweetin, Executive Medical Director for Essex ICB.
I'm Mike Thorne, Chair of the Essex Integrated Care Board.
Tom Abel, Chief Executive of the ICB.
Good afternoon, Jane Kearton. I'm the Executive Director of Finance and Commercial at Essex ICB.
Mark Balaam, Non-Executive Member of the Essex ICB.
Good afternoon, Neha Brown, Non-Executive Member of the Essex ICB.
Good afternoon, Rex Smith, Non-Executive Director of the Essex ICB.
Good afternoon, Jo Churchill, Non-Executive Member of the Essex ICB.
Good afternoon, I'm Sarah Muckle, Director for Wellbeing, Public Health and Communities with Essex County Council.
And good afternoon, I'm Rob Percy, I'm the Executive Director of Health and Adult Social Care at Thurrock Council.
And afternoon, Mark Harvey, Executive Director for Adults and Communities at Southend City Council.
And our support team over there. Thank you. And Paul, I think this is your last meeting in your current role here. Just to say thank you for the contributions to this and predecessor bodies over those years. They've been much appreciated, and everything's been done in the spirit of working together to make things better for the population we serve. So thank you. I've been given a list of apologies, which I'm not proposing to go through. On the register of interests, we don't yet have an entry for you, Tom, and for Rex. I don't think there's anything on the Part 1 agenda that we've got here today. Michael?
Thank you. So just to say that Tom submitted his interest to us this morning, so they'll be reflected on future registers, and there's nothing to be of interest for this meeting.
Okay, sorry, nobody tells me anything, but there you go. Thank you. And Rex, we'll need them from yours if we haven't already. Thank you. We've some questions from the public. 2 inquiries were received regarding the performance of Mid and South Essex NHS Foundation Trust. And I think, Tom, you're going to respond to that.
Yes, thank you, Mike. From the 1st of April, the new Essex ICB took on the role of Strategic Commissioner, and as set out in national guidance, we have responsibility now for long-term planning, quality oversight, and securing consistently high-quality care for the residents of Essex. We'll be working across the county, and we'll use all levers available as the Strategic Commissioner to drive improvements and respond to concerns about any services that affect local residents. We have also done a response to the inquiries that were made to say it might be more appropriate for this question to be directed to Mid and South Essex Foundation Trust for a more detailed response around some of the issues identified.
Thank you. Linda Ward raised a question which related to a personal matter. I think rather than an item on the agenda, we have responded to that directly to her on the grounds that it was both personal and not relating to the agenda. We've had a number of questions from the press, and those have been redirected to those people who handle questions and comments from the press, so they will be responded to, but not here now. We had a question from Peter Blackman concerning what patient and public two-way engagement is being set up for alliances or the new proposed local authority areas and the new neighbourhoods as we move forward to implement neighbourhood setups as required by the government. And I think, Tom, you're going to respond to that.
Yes, thank you, Mike, and thank you, Peter, for your question. I think we are really clear as an ICB that we recognise that strong two-way engagement with people and communities is essential to maintaining and rebuilding trust in NHS services, and we are committed to ensuring the views of residents are at the centre of our decision-making processes. At neighbourhood level, we're keen to strengthen partnerships with the VCSE sector and existing community networks to ensure residents can both shape and respond to local priorities and build a more collaborative relationship between NHS services and trusted community voices. Following the elections in May, we will begin wider engagement on our population health improvement plan to test our ambitions with residents and to ensure their experience informs plans at both system and neighbourhood level. A further update on our approach to how we intend to work with people and communities will be shared at a future board meeting. But in the meantime, we'd like to thank Peter and groups such as the Southwood and Ferrers Health and Social Care Group for their continued commitment to representing local people, strengthening community voice and supporting constructive dialogue with the NHS and other partners.
Thank you. So we now come on to the approval of the minutes of our Part 1 meeting on the 1st of April, which was a whole host of important and largely technical matters. Any comments on the minutes? And if you're new round this table, we assume silence means 100% agreement and happiness with those minutes, yeah? Thank you. Any matters arising anyone wants to raise which are not on the agenda from those minutes? Again, that'd be surprising because it was very technical material. And we have no outstanding actions from that action log because those things really did have to be done on that day. So that brings us on to our first substantive item, which is the Population Health Improvement Plan. And Tom, that's you.
Thank you, Mike. We obviously signed off and approved the Population Health Improvement Plan at our meeting on the 1st of April. However, it was noted at that meeting that there were a number of matters of accuracy that needed correcting within the PHIP, and so the main purpose of bringing it back today is to assure the board and confirm to the board that those technical amendments have been made. Alongside that, within the pack, there's also a slide deck that we are starting to use and will continue to use around some of the engagement activities that we want to undertake around the PHIP to make sure that it is fully informed, as I said in my response to the question from Peter, by local community and patient and resident views, but equally obviously all of our other partners that we work with across Essex.
Thank you. It's here, and if there are any further questions or comments, I'll happily take them. Mark.
Just to say that the Commissioning Quality and Resource Committee considered the Population Health Improvement Programme, and one thing we raised was how we monitor going forward as part of the committee, how we are delivering on the plan so that we can have a more structured approach to, this is what's happening, this is where we are, this is what we need to do in order to meet the expectations of that.
Which we agree with. The work that's currently going on is to start to build each of the elements of the Population Health Improvement Plan into very clear delivery plans. And so the intention is to make sure that the committee receives a routine report in terms of the update on progress. And that will be reflected also through, obviously, in terms of the reporting from the committee into this board as well.
Thank you. No other comments then, we'll move on because that has seen quite a lot of exposure, so to speak, around this and its predecessor tables. So then we come then, in your own right, Tom, to Chief Executive's report.
Thank you, Mike. So my report covers a number of items. So firstly, I just thought it'd be worth confirming that we've continued to make good progress around the transition to the new ICB, and we are now at the final stages of our organisational change process. And we're standing up now in terms of the briefings for all of the new team members within NHS Essex around the future role of the ICB, but equally also in terms of the work represented in the Population Health Improvement Plan and the work that we need to do in terms of the co-design and creation of the new culture and the sets and ways of working that we want to establish for the new organisation as well. Also to note in terms of 26-27 planning, so alongside the Population Health Improvement Plan, we also did do a resubmission of our numerical plan to NHS England, particularly focused on the progress that has been made by Sam and Jen, particularly around tackling the waiting list position, particularly at Mid and South Essex Foundation Trust. We are now working towards around about a 50,000 reduction in the Essex waiting list for elective hospital treatment over the course of the coming year. And we've also been able to submit improved positions around all of the other core access standards. Those numbers will be reflected back into the reporting that we see through this board in terms of the progress that we're making. I've also reflected within the report the guidance that has recently come out around neighbourhoods and neighbourhood health. After the production of this report, we've also seen guidance around new neighbourhood health centres that we're working on and obviously talked about in our seminar session earlier today. Resident doctor industrial action, there's a brief update, but clearly there was a lot of work that was done by colleagues across the NHS in order to make sure that we continue to provide safe, effective care across Essex over that period. And to note, obviously, there is potential further industrial action both by resident doctors, but equally also by consultants and general practitioners as well, that we may need to respond to once we know the outcome of the various consultative ballots and things that are going on in that area. And then finally, just to also note the work that we've now got to a point where we've agreed our strategic objectives as an organisation. So those new 5 objectives are the work that we will do in terms of narrowing health inequalities for the people of Essex. Secondly, the work around securing a decisive shift towards neighbourhood care delivery and prevention. Thirdly, improving access and outcomes across services. Fourthly, financially and clinically sustainable services across Essex. And finally, our own internal work that we need to do in terms of making sure that we're up to the job, we're good to work for, and we're good to work with as an organisation. And so that will start to help frame the conversations that we have around this table, and obviously areas like our board assurance framework and things like that as well. I'll pause there, Michael.
Thank you. Questions or comments on Tom's report? Joe?
Thank you, Tom, for your report. You mention in it about items that you've delivered already that potentially can be scaled up. I wondered if you could talk to some of those positives where we could see quick wins. And then what does success look like? And how are we going to do it and make sure we've heard the voice of the residents of Essex, the patients, the customers, to make sure we really are delivering in line with the PHIP and other objectives? And finally, what does the evaluation of it look like? How will we know we've done it well?
Thank you, Joe. So I'll respond in terms of somewhere I think we've got scale-up opportunities. Michael, you might want to talk a little bit about some of the work we've going, or the conversation we're having with Health Watch as well, in terms of the views of local residents. And equally, obviously, I can talk a bit about evaluation. So we've done some initial work in terms of looking at some of the metrics across Essex around where there's good performance. And so we know that we've got some really good examples around frailty identification, care planning, which has led to reductions in acute demand. So we want to build on and scale on that consistently across Essex. Equally, we know that we've also got some really good practice in some areas of cardiovascular disease identification and prevention. Again, we want to look at scaling that up, ditto diabetes. So we've got a few areas we can really start to crack on with in terms of improving outcomes. The way that we will evaluate and measure that is there's good established measures that we have, and so we'll start to see the outcomes from that. I'm sure alongside that, we're going to need to do some work around some of the additional, more aspirational areas we're going to want to get onto around what are the new metrics or ways we will go about evaluating things. And so we'll probably dual track it a bit. So there's some tough kind of hard yard implementation work, which we'll see the results of. And there's probably also going to be some parallel developmental work in terms of trying out some new things in some of those areas that we haven't got into yet. But Michael, do you want to talk a bit about Health Watch?
Yes, and I would say more generally, Joe, I think is a really good question about how we, or a good challenge, I guess, which is how we can do more to make sure that the voice of residents is engaged, both in our general direction of travel when we develop strategies like the PHIP, but also in the decisions we make within those strategies as we decide, take decisions around commissioning particular services, etc. So as a team, we are doing a lot of work to consider what our model will be for engaging residents in our work moving forward. And I think it'd be really good to bring that back to this board so that we can have a conversation about that. So that's the broader point. In terms of the PHIP, we recognise that actually there are going to be cohorts of our population within Essex that are going to be less likely to be engaged in our work, and that we need to work a little bit harder to make sure they are at the front and centre of the work that we're doing. So we are having conversations with our colleagues in Health Watch across the component parts that are making up Essex, recognising that they themselves are going through a period of change, to develop a model for the support they can offer to the ICB in doing that. Because probably at the heart of that conversation is a recognition that as an ICB, we are not best placed to be able to have a comprehensive engagement effort across the whole of of Essex in the way that we would like to do. Health Watch are the experts in that space, and we're really keen to come up with a model where we can continue to utilise them so they can help us to make sure that we're doing the engagement we need to do around the plan.
Thank you, Rob.
Yeah, and it's probably just worth mentioning, just to build on that across Essex, outside those formal structures, there's lots of other things that happen. So, for example, in public health, they often focus their work in areas which focus on inequality, which is some of the more difficult groups to sometimes engage with. And so we can use the existing programs as a mechanism to engage with those communities through what we're already doing. And the other obvious one to mention is obviously because local elections and councillors generally, ward councillors, they tend to, the media tends to always focus on bin collections and street cleaning, but actually a lot of ward councillors that I experience, they have a very strong interest in the NHS and their constituents talk to them about it. So there's the formal structured arrangements which we're looking, but there's those informal relational ones which as a system we can work more on helping to inform how we go forward.
Thank you. Could I ask, obviously our staff have been through a transition, or the staff that we now have, because we've got people who are in 3 different ICBs. We've got new colleagues. During that transition, we've said goodbye to a lot of colleagues, many of whom have given a lot of service to the NHS and so on. And all of this was, because the government asked us to do this, and we've done it, and I believe we've done it as well as anybody could have done because of the kind of lack of things that have come up from the process. It seems to have been handled well, so thanks to everybody involved in that. But now we are the new Essex ICB. So in a sense, the question I really want to ask is, what work is in place to sort of try and make sure we get a really good staff satisfaction survey in a year's time, because we want to get the best out of these colleagues, don't we? And we need plans to bring people together into the new whole, because they've come from the, so to speak, the 4 corners of the NHS and other worlds, and also to feel that they belong, and also how do things go around here. So could you just paint a picture for people who might not be familiar with that?
Yeah. Of course, you're happy to, and I think that I would start by saying that as an executive team, Tom mentioned earlier the corporate objectives of the organisation. One of our recognition of the importance of doing that work around organisational design is that we've made one of our key corporate objectives making the Essex ICB a good organisation to work for and with, and that's absolutely a critical activity for us over the year ahead. So in terms of how we are going to do that in an OD way, we have developed a utilising existing evidence-based plans and OD programmes that are available. We've developed a plan for a comprehensive OD strategy for Essex ICB that will look at doing a number of things. So the first is looking at what drives staff satisfaction, both at its current level and improvements in the future. And of course, we need to recognise we've been through a change process, but we also need to recognise that across the board, NHS staff satisfaction wasn't where we wanted it to be, even going into that process. So there's a broader conversation to be had. And so that will be one plank of it. A second plank is that we are keen to make sure that the Essex ICB is an organisation that is closer to the services it commissions and the people that use them, and that goes back to some of the conversation we were just having about our patient engagement in the PHIP. We are also very keen that we do some work to strengthen the roles of our line managers in building that culture and that organisational approach and ways of working we want to see, and ensure that everyone in our organisation has a clear understanding of their kind of individual accountability and contribution that they can make to delivering the plan that we've got. And then finally, we recognise as well that in relation to equality, diversity and inclusion, in line with the whole of the NHS, there is more work that we need to do to create a more equal organisation. So there's work that we need to do there. Underneath all of those 5 pillars, there is a plan for how we choose to do that. Some of it is around engaging our staff to understand what's driving their kind of feelings on this, and making improvements as a result. Some of it is around kind of more traditional training around sort of objective setting, appraisals, etc. But we have a plan. We have started to implement that plan, and we will happily keep the board updated as we go through.
Neha?
Yeah, thank you, Michael. Just to follow up on that, I don't know if I missed it in the 5 pillars. One of the things that will be quite crucial as in the new organisation, the staff, we know, especially looking at our strategic commissioning and the skills we need for that, we will have those skills, some of them, but others may need to be developed. What are the plans in terms of making sure that as we grow, as we develop, we have the right framework for it?
Thank you. I think I did that thing where I said there were 5 pillars and I may have only done 4 of them and missed one. So you've absolutely pulled me up.
I wondered if I was having a nap at the time.
Quite rightly. So that is the 5th pillar, which is that we have to recognise that we have an organisation which has a very different function to the organisations that came into it. A first step of that is that actually, although, as the chair said, we've reduced our establishment overall, we do in our new structures have some staffing gaps where we will need to go out and recruit because they're in areas where we didn't have the existing skills and capacity. So, for example, things like analytics, which are going to be absolutely crucial to that strategic commissioning role. So we need to do more there. And then there's something about, and again, we're developing the plan for this, how we support our staff more widely across the organisation to develop further those core skills that we needed to be successful strategic commissioners. So that will be about the use of data, consistent reporting, etc. So clearly all of this is something that will be taking place over the course of the year, and we will see results as we go through that. But yes, definitely that's a key area of focus. I'm sorry I missed it.
How best, Tom, to keep the board aware? Is it by sort of having, a regular update within your report or a separate report? I'm just conscious that in the new way of doing things, we meet 4 times a year. So, we'll be well on the way the next time we meet to the next staff survey. So it would be good to get that update.
Yeah, we'll take an action. So me and Michael work together, and if we can reflect it within my report, or have a separate update to the board members.
Lovely. Thank you very much. Okay. Any other questions on the Chief Executive's report or comments? No. Thank you very much indeed. So we move on now to Commissioning Quality and Resource Summary Report. And again, I think this is setting us fair for what we need to do next, isn't it? Who's going to speak to this?
I'll pick that one up, Chair.
Thank you.
So I'll talk to the report, which is different to what members of the board might have seen in previous guises as we move into a new world of strategic commissioning. And I'll give way to Sam and to Natalie as well, because what the board will be in receipt of when we meet quarterly will be a report from the Commissioning Quality and Resource Committee. So there is a subcommittee of this board, which is chaired by Mark Phelan, one of our non-executive directors on my right. This is an opportunity for us to, we had our CQRC meeting just yesterday, the day before Tuesday. So some of this is still verbal, but as we move forward, we'll be able to get a contribution from Mark in terms of that position, and Nihar as vice chair as well. What we wanted to do today, given when we went to publish, we were 2 weeks old as an organisation, was just to start to frame and ask the board for input into how what other information they might feel useful, what other information they might like to see. So I cannot stress enough that this report has dummy data in it, and I had to be very, very careful to make sure that the dummy data was there. There are elements that are real data, which I will touch on as I go through. But this will also help provide the board some assurance that actually, as the governance structure works down throughout the organisation, Mark and Nihal will have seen elements of this report already through the QCRC. They would have had more detailed deep dive discussions around that as well. So hopefully we'll be able to join some of those dots together as we report throughout the year. So just in terms of the pack itself, the first couple of slides actually start to set the scene for Essex. So the board, the joint committee, or the Essex Joint Committee is the precursor to the Essex board, signed off the plan for Essex NHS in March. So we have seen the pie chart and the resource allocation and application will be familiar to members of the joint committee, as was, but this shows how we are distributing the £5.3 billion that will be in receipt of in Essex, NHS Essex, to be able to provide, to commission the provision of health services across the county. The pie chart that's in there is our planned spend profile. Why that normally comes out once a year at the annual report stage. So we want to give that an airing every quarter so that we can start to see how things are moving, given that we've made commitments about how we change that profile of spend as we go through our medium-term planning round as well. So hopefully that will start to become more familiar to people. And indeed, in the QCRC, we dive into different parts of this pie chart in different ways as we go through each of the quarters. The other element that, just to share with the board today, is the capital resource and allocation plan. So again, this was seen at a high level when we signed off the submission in March. There's slightly more detail in here too. It's important to note that we start the year with some uncommitted resource there, which I think is actually quite helpful, given we are still going through due diligence and transition around the inheritance from the 3 separate ICBs, so that we can be clear that we've got all of the commitments underlined and that we're putting them all through the same prioritisation process. As you move through the pages, I'm now in the executive summary space, which is blank, but this will be an opportunity for Sam, myself and Giles to give you an overview of some of the key challenges that we faced in the quarter, some of the key bits of progress we've made, key opportunities, risks, and also to be able to touch on a bit of triangulation between those 3 pillars within the organisation across commissioning, quality and resources. The real proof of success will be when Sam and Giles can present my report and I can present theirs. We'll definitely be triangulated them, but we'll leave that for a later board, I think. But hopefully that will just be able to allow the reader a way into the report, which then we'll start with finance. So key financials, we will focus the majority of our time on financial trends. So we know what our plan is. We will look at the trends of how close we are to that. We will understand the risks to delivering that trend. So if we carry on the way we're going, where will we be in 12 months' time? Where will we be in 24 months' time, thinking about that multi-year planning period? So the key aspects that we wanted to draw out in here are the efficiencies that we still need to deliver and the risk and mitigation profile as well. We'll also look at building out so that the board will become familiar with the spend areas that each of the executive directors has responsible for in their portfolio. We'll be able to draw out the trends, and they'll also have a voice in this part of the report if there is anything that they want to flag in that space too. So at the moment you have a sea of green, the dummy data. The focus on spend areas takes us into a little bit more detail. And as I've said, we'll look at current period performance, projected performance, and the risks to actually delivering that projected performance. And again, here will be the opportunity to give us some narrative around key movements and mitigations. The report that Mark and Neha are members of the QCRCC is a level of detail much deeper than this, many lines, and this will be a summary of those, but obviously you will have input from Mark as well as the overview of the committee. And we'll also have technical annexes, so we'll be keeping an eye on our cash flow, our better payment practice code, etc., debtors and creditors, and the technical finance annexes that you would expect to see. In terms of capital and estates, there's a couple of new areas on here, and these represent the importance of a couple of key strategic things for us in Essex, which is the progress around Section 106 monies, which are the monies that are held for planning development mitigation, so the consequences of planning developments, housing buildings, etc., and the impact that they will have on health. There is mitigation funding that is held with that. Some of that is very long in its time frames, so actually the progress we will see will be how we're accessing that, how we're spending it, plans, pipelines, etc., and also the neighbourhood health estates progress. So we're really aware, and we've seen a lot of the guidance is coming through now in terms of the ambitions around the neighbourhood health and what that looks like for our estate portfolio across the whole of Essex as well. So we'll be able to keep the board abreast of those kind of things. Just before I give way to Sam and Natalie, just to touch on contracted activity. So a slide of blank charts at the moment. What we want to be able to start employing is a concept called making data count, which is in the NHS. So we'll be looking at those statistical process control charts in here. What that will allow us to do is look at data over a series of time, so that we can actually see, is something just a blip or is something actually a real cause for concern, so that we can make some better decisions, have some better conversations about the data, rather than me just showing you this is how we performed last month, this is how we expect to be performing by the end of the year. Hopefully this will enable the board to be able to see some of that divergence from plan. We'll need probably good 3-4 months worth of data before we can really start to do anything meaningful with this slide. So we'll look to make sure we can give you a state of the nation type report at the next board, and we'll build up the SPC input. I also think we'll probably over time want to look at more of these charts. So we might want to put some more stuff in there around dental access as well, and the optoms and other aspects of Essex ICB commissioning. We might also want to break it down in terms of type of area as well, whether that's NHS, non-NHS. So really open to having this evolve as we go through the board meetings. And hopefully, like I say, by the time we meet again, we'll be able to have some information starting to flow in this space too. And this is all about ensuring that triangulation with the finances. So you'll be able to see this is what we are buying, this is what we're receiving, this is what we intended to receive for our population, and this is what's actually happening. And then Sam will be able to then connect that with, seamlessly, the performance metrics and where we stand in terms of the eyes of NHS England more broadly. So we've got a couple of slides in here, Sam, for you. I don't know if you want to talk to them.
Thank you, Jen. So as Jen's indicated, there are a couple of slides within the pack related to performance and to caveat. Again, this is dummy data. And these two slides will give an overview of the responsibility that the board has in relation to the National Oversight Framework and the operating plan and the metrics associated within that. They are traffic lights, so they'll be RAG rated, and we'll be able to see how we are progressing each quarter. We'll have the ability to have some narrative within here that indicates how we are performing against each of the quarters and whether we've got any movement, whether that's positive, negative, and the narrative will support that. We'll also be able to indicate in here if there's any remedial action plans that need to take place to be able to give us any recovery should that be the case. It will also have the ability to demonstrate how we are performing as an ICB in the NOF. So we'll be able to see how we're performing as a region and equally where we're sitting nationally as well. So we'll be able to bring that here forward.
Thank you. I was pleased to see this because I've seen some of these SPC charts for the Norfolk and Norwich Hospital who use it to report, and they really do give you a very quick, clear sight of what is actually happening underneath all this. So I welcome it hugely. Nia, Mark, either of you want to sort of talk about your views on this?
I mean, we went through the more detail, also the proposal for the more detailed, suggested some additions. It'll be easier once data starts getting populated, because then you can see what works, what doesn't, and when it leads to a further question, okay, should we build that within the report? So I think it's a great kind of first start, but it's something which will evolve over time. So this isn't necessarily going to be the final version; it's just the starting version.
Neha?
Yeah, I think just to add to that, and we discussed that committee as well, the bringing together of the three strands and putting them in this is exactly what we had been wanting to do and aiming to do even before this came into place. The downside of sometimes seeing the data all together in one place is that where there are blips, as you mentioned, when they will start appearing, to have that clear focus on picking that up, it gets lost when you have so much in front of you, even if you have highlights. So a mechanism to do that, maybe even a focus each meeting or each time or each quarter on something would be quite helpful. But the other thing is, in all these metrics, which we are national metrics, so we can't really argue with them, do we have an ability or a plan to actually build it? For example, for any of the commission services we have, patient satisfaction, which particular metric are we looking at that brings it out straight away and to say, yes, we've commissioned this service, it's on plan, it's on budget, it's doing well. What about the patient satisfaction aspect of that quality as well? How does that come into? So it's something to think of, Jen. It's not necessarily what, but maybe Natalie has a point to that.
Absolutely. I think this is firstly, it's the art of the report, how it's formatted in that triangulation that then kind of generates the conversation. So there's something about going with curiosity from the data in front, and so that we curiously seek what is the patient experience, satisfaction, and I think that's where Michael in the plans laid out with Health Watch, as well as our own internal intelligence and how we work with partners around patient experience, can draw that in. But I would also fully agree with you that we need that also state of the nation around what patient experience and satisfaction is looking like, so that we can see the early indications and further triangulate with this report.
I was just going to build on what Natalie was saying, because obviously quality is a huge part of this report, but actually we will be talking about quality as well in our audit, risk and compliance committee, which only just met yesterday, so it's been a big governance week this week. But the audit, risk and compliance committee is where Giles will be bringing that kind of statutory standards report. So as the board evolves, there will be a similar report from the subcommittee of the ARC, so that committee as well, which will pick up some of those aspects. But we need to make sure we've got the right measurements to inform the conversation. And I think this is definitely going to be a skill for Sam, Giles and myself in that executive summary, to be able to pull through those golden threads and really flag to the board where we want to be able to focus attention.
And for example, where you've put the narrative alongside the focus spend areas,
Yeah.
actually that would be really good to see that alongside it as well, not just the numbers. No, thank you. This is really positive, actually. This is exactly what we want to see.
Joe, were you looking to come in? No. Agreement, okay. Yeah, I mean, I'm just conscious now, because we don't meet until we're at the end of Q1, which is by which time, money could have gone wrong. It's not our history. I doubt it will, but if you see what I mean, it's a long gap. So, we definitely are going to be expecting these to be populated with real data, yes, aren't we? Next meeting, because it's quite a long time, and this is a silly thing to say because it only existed for 23 days, or not quite yet 23 days, but the anxiety should be there because we don't want to get off plan.
Yeah, correct.
And just to reassure you, Mike, that the executive committee will still be seeing monthly what that actual position is. So should there be any early warning indicators that we need to escalate, we'll do so.
Thank you, Paul.
Yeah, thanks. And it's really interesting to start looking through different lens as an ICB when it becomes more strategic in its commissioning. I was really interested to see the plan spend profile in section 2. And I won't ask the obvious question, don't worry on that one. But the connecting that with the strategic intent of this board, and having a target, I guess, where the money's going to be spent over the next 3 years. Is that something you plan to develop over time? I know we're 23 days in and we haven't got it already, but it'd be good to be working towards that.
Yes, that is the work of the coming months in terms of how do we develop, how do you do that, and what is the work that we're going to need to do in order to see that shift over time. So yes, that's going to be the work of the summer, I think.
Just to add to that, I think the shift that the QCRC will see as well, that's only going to meet quarterly, is it's not just going to be talking about this year's financial position. Each quarter it will be talking about next year's as well. So we'll be looking at that rolling 2-year projection, which I think will be helpful to keep an eye on that.
Thank you. I guess the other question, and it comes more to mind when we go on to the neighbourhood report, is how can we assure ourselves that we are addressing the headline requirements of an integrated care board to achieve from the government, so to speak? So, you know, we've gone down into detail about we're doing this and we're doing that because we want to achieve what it is happening. So how do we meld them together so that somebody reading our papers could easily be persuaded that we are indeed working on those government priorities? Tom?
Yeah, so we need to do, so there's more development to do around some of the performance metrics. So I think we will get the new national oversight framework published soon, definitely before the next board meeting, I'm told. So I think we align our performance reporting to those domains, because then that directly links into the expectations in terms of what we're supposed to deliver as an integrated care board, but then also links through into some of the questions around reducing health inequalities. We do really need to have a look at some of the areas of responsibility to say, have we got a good set of metrics? So if you think about some of the kind of economic inactivity kind of work or duties that we have, we might need to think about what measures or metrics can we put in place in order to be able to evidence some of that as well. But we'll start with the National Oversight Framework. We can align that quite easily to the statutory duties of ICBs, and we can build from there.
Is this an area where, you know, our council partners would have metrics that could be sort of redeployed potentially?
Yeah, and we've also, it could be bringing in, so we've got work well pilots going on within Essex, for instance, and so that's some of the work we're doing with DWP. They don't form part of the sort of the national NHS driven oversight arrangements, but there will be metrics and measures coming out of that. But equally, if you think about some of the core measures around primary prevention, screening, vaccination rates, things like that, there's probably quite a lot we could join up with, say, Sarah and colleagues in Southend and Thurrock around doing some of that, bringing some of that data together, so it's telling us a richer story about what's going on and what the work is that we're going to need to do in partnership with others to drive improvement.
Sarah?
Yeah, when I was looking at the neighbourhood health report, I saw the reference to Work Well, and the local authority has Connect to Work. I'm told they're very different programmes, but if you read what they are, actually they're targeting exactly the same people. So Work Well, integrated holistic health for people with health-related barriers to work. Connect to Work, personalised employment support for people with disabilities and health conditions. So it feels like we should put the two leads in touch with each other, but also the health determinants research collaboration is doing a really comprehensive evaluation on that Connect to Work programme. So there's opportunities, I think, to learn from both and even potentially to influence that evaluation. It's not started yet, but it feels like we could target the same people with slightly different messages.
Thank you. Any other questions or comments? I mean, this is the start of a good journey. Rex?
Thank you, Chair. The section 11 in your report and section 12 aren't they an attempt to address the issues that the chair raised about, you know, how we're doing against national targets? I don't see anything on neighbourhoods in there. There may be something, but But the one question I did have, I mean, it'd be great when you get this, how long does it take for this information to actually land on your desk so that you can put this together? Or is it available online that you can dip into at any time?
So at the moment for Essex, we're working through making sure that all the contract activity flows are going in the right way. So obviously we have information that we are now is new to us that we didn't previously receive. So the contracting activity churn has a long lead in time. So obviously the activity has to come through, the acute providers and all other providers come through, be coded, be invoiced, etc. So there is quite a time lag on that. I would expect by the time we get to June, July, we'll be at what we call flex and freeze dates. So we'll have some data indicative there that we'll be able to do. For the finances, we will have a month one position, which will be really high level, but by the time the board meets, we should have at least those 3 months worth of this is what has happened. I think that the hope is that we'll start to be we'll spend more time talking about and what does that mean for what's going to happen, rather than, and this is the performance of what has happened as such, that we have less control over, but what does that mean for us moving forward? But indeed, Beverly, as the Exec Director for Neighbourhood Health, we've been having a conversation about what metrics we put in here. And I think the conversation previously with Tom and with Sarah actually challenges us to think a little bit differently, so that we're not just, that we actually start to understand what we want to watch locally, as well as what our commitments are to watch nationally, and how do we locally present our finances so that actually they could potentially be more meaningful for some of those spend areas that we've talked about, which might not trigger a huge proportion of the 5.3 billion, but could have a really material effect on some of the outputs and outcomes that we've got in Essex.
I mean, this would be great to have this data.
Yes.
I'll be very surprised if it's readily available, but pleasantly surprised. The one question I did have, I know that there's not much finances in here, but that's fine. These are
Within the metrics themselves, the national metrics, yeah.
Forgive me if I should know this, but what is the number of active inappropriate adult acute out of area placements? You know idea what that is?
I'll pass over to Sam in
I didn't
terms of
know what that
mental
was.
health.
So Rex, I can answer the two questions. One, in terms of the readily available data, a number of these metrics here, which are driven from our providers, and equally what we're responsible from an ICB perspective, are real-time data entry. So we'll be able to have some readily data for our next meeting. And I'm confident with that in terms of those data flows. With regards to the out-of-area placements, that's in relation to mental health. So that's a mental health metric.
Thank you.
Tom, you want to come in?
Yeah, so I think the hope will be so I think we could probably structure the metrics in terms of, so we're clear in terms of responsibility and which aspect of sort of the ICB responsibilities, where it sits. So, is that being driven by the neighbourhood team? Is it being driven by Sam's team? So you could be clear in terms of the accountability flow and how that operates. The other thing, so I expect that this will be the last iteration of the neighbourhood report in its current form, because I think we want to extract the core performance material out of that, which will then be reflected within the CQRC report, and then the neighbourhood report then becoming effectively a report from our neighbourhood committee, which reflects on sort of the development work that we want to do around neighbourhoods. And so you'll get sort of a performance angle, and then you'll get a developmental angle, and so the two aren't getting mixed up as we move forward. So that's our aim for our next meeting in terms of to make that transition.
Joe?
So thanks, Tom. That was a little bit around my question, because as we start to do all this left shift work and so on, we need to start thinking differently about how we're measuring things and what we're doing out there, or else we're just measuring the same old. So I'd also like to know what point do we start putting very firm timelines into some of this work, rather than, I know that we're reporting on, quarterly on this, but what is the drumbeat? Appointments in general practice, for example. That was quite a difficult one, quite honestly, because we're trying to drive them down. We're looking at pharmacy first, for example. So if we are working well with this agenda and we are helping people navigate our systems better, I suppose the thing that's confusing me slightly is what is it we are really looking at here? And what is the underlying detail? Because if I have done my work properly, I will have people using different pathways for their care, and they should be dropping out. Well, does a sort of less activity mean a poorer result, or is that actually a mark of success? I'm sorry, that's quite a big question and probably sits in the next one as well. It's probably for Matt.
I mean, you've hit the nail on the head, Jay. So we will have national metrics, which will still be our paymaster, which we must report on. Our job, particularly in the clinical space, but across the operational space, is then to translate that for you and for the board. I use frailty as an example. So what we know in the frailty space is the national metrics will be very much around hospital admissions and potentially admissions at the end of life. So high level, some proxy markers. We know the evidence-based interventions are around something called a comprehensive geriatric assessment, which looks at medicines, falls, and care planning at the end of life. We need to capture those and see they're being done. In practice, what that means is you spend longer with individuals, but targeted individuals in high-risk cohorts. So we need to still support you to provide the narrative that actually, in some cases, activity rightly needs to go down, but the quality of what the intervention is needs to go up. And so we need to ensure that we report, in a sense, to our paymasters, but we also need to report on what I would say is the proper clinical quality outcomes. And that's what we're grappling with. The joy of our system is a lot of our data flows are aligned in primary care already. And we've had some brilliant clinicians to sort out the coding for us. So we do have that in play. And our job in the next month or so is to bring those two together.
Because ultimately we want better healthcare for Essex.
Not widget
rather
counting.
Than,
yeah,
yes.
yeah.
But I think there was another bit of your question really as well, which is, you know, Tom, how will you manage all this through? You'll have different dials, so to speak, on your screen.
Yeah.
As you watch the progress of people moving things to where you want them to get to. That was the other part of the question.
Yeah, so there's the importance in planning, isn't it? So I think there's the numbers themselves, and then there's the contextual information around those numbers, partly as Matt said. So behind each of these numbers, we have got agreed trajectories and agreed planned kind of it's going to get from X to Y over the course of the next 12 months. So we will be able to report whether we are on track in terms of the delivery or not of those things. Now, if we're not on track, there's then what we need to be accounting to you for is what action are we taking? So what commissioning contractual action are we taking? What commissioning action are we taking, et cetera, et cetera? Or B, actually, it's okay that we're not delivering this because actually this other thing has happened. But we're going to have to get quite smart and slick at how we do that, which is partly why the exec is going to be looking at this more frequently than the board, because it's going to require, I think, a change in thinking for a number of the people who work in the ICB around some of those disciplines and the absolute sort of delivery focus that we need to have within the organisation for the coming year, and to make sure we are delivering on our job and our duties.
So, because personally, is the number of admissions from care homes diminishing as a true sign of our success?
Yeah. And in answer to the point that Rex made, these numbers on charts 11 and 12 are highly relevant, but our task that we're given is to kind of radically reconstruct what outpatient appointments are used for and to make sure that every single one of them counts and isn't unnecessary for clinical reasons, because the evidence is they're not necessary, and so that we're using our time sensibly, and just these bald numbers won't help with that. Probably need to move us on. Thank you very much for that, and thanks to everybody whose work has gone into that. And now the proof of the pudding will be in the eating, and the promises have been made for our next meeting in whenever, how many months it is time. Thank you. So on to neighbourhood report. And I think in the absence of Beverly, that's you again, Tom, is it?
Yes, sorry. So I won't touch on the data side of things, as I've said that we will be working on incorporating that into the Commissioning Quality and Resource report as we move forwards. And I think this is the last form, as I've said earlier, of this report in its current form. I think some of the things just to kind of draw the board's attention to, there's an update within the report around the National Neighbourhood Health Improvement Programme that we have in place in North East Essex and West Essex. And I think that is progressing well, and there's an opportunity for us to take the learning from those pilots and start to deploy that elsewhere within Essex. There's equally also an update around some of the contractual changes within primary care, so particularly within the GP contract and the dental contract, and the work that is going on at the moment around the development of the action plan for primary care that NHS England has expected all ICBs to undertake. And then the final area that I just wanted to quickly update on was, as that's set out within the Population Health Improvement Plan, we are moving ahead in terms of the work around defining and scoping the community services review, with the intention of that going for approval for the terms of reference for that work to go to our board meeting, our executive team meeting next Tuesday. And so that will then start a report through to the board, and so there'll be a further update on the progress of that work next time we meet.
Thank you. Can I ask, is the actual review going to be undertaken by ourselves alone? Are we getting outside help? I have no axe to grind. I'm just asking how it's going to be done.
So within Beverly structure, there is a couple of time-limited roles specifically dedicated to undertaking this task. Those individuals have been involved in similar work elsewhere, so we can learn and build from the work that particularly has already been undertaken in Herts and West Essex. So we've got that learning we can bring to bear. We'll keep it under review in terms of there might be the need for some external expertise in certain areas, but we'll see how we get on, I think.
Okay, good. And because we need the outcome from that, don't we, before we can move forward on a number of different issues. Questions, comments on the neighbourhood report from anyone? Tom?
It was just with regard to the comment around developing partnerships between PCNs, community providers, when it comes to the neighbourhood health teams. I was at a national primary care conference yesterday when I was arguing the point that acute trusts in many cases also need to be part of forming those teams. A few reasons really. I think there's many reasons why acute trusts are incentivized for neighbourhood health teams to be really, really successful. It reduces the burden on acute organisations, allows our clinicians to operate at the top of their licence and treat genuinely acute people. Often within a local area, even though we're all financially constrained, it's acute to have the biggest budgets and resources when it comes to delivering some of this stuff. And I think we need to be thinking about how, as part of the leadership, we can offer those resources to local neighbourhood teams. And of course, quite often, what allows a patient to remain at an integrated neighbourhood team level rather than going to an acute could be remote secondary care advice channeling into that integrated neighbourhood conversation. So again, a small point relative to the paper overall, which I completely support, but I do think acutes need to be part of that neighbourhood health team conversation.
Yes, yeah, I agree.
Okay, agreed. Thank you very much. I'll move on then. Thank you. So items of general governance. There's the board forward work plan, Tom.
Yes, so this is the proposed ICB board cycle of business for 26-27, and so this is here, I think, for noting, and it basically sets out in terms of what we will work through over the course of the year, making sure that we attend to all of the various statutory obligations that we have on us as an organisation.
Thank you. Any comments, questions? No. Thank you. And risk framework update. I mean, it basically says we're going to have a workshop.
Michael, is there anything else to add?
Oh, well, that's quite a good summary. We've included this paper because we obviously haven't brought a board assurance framework to this board because of the, as we've already covered, the amount of time the organisation has been in existence and some key things, including having a workshop that we need to do before we can pull that board assurance framework together. So this is a holding update, just to assure the board that we are in the process of developing the risk assurance framework that the Essex ICB will follow, and for the next meeting of this board, we'll be in a much stronger position and able to present a board assurance framework.
Thank you. I mean, it is a crucial vehicle, that for monitoring our progress. Everyone okay with that? Thank you. And then this is a technicality which we, in integrated care boards, you have to do every year because of the timings of things that have to be sent upstairs, so to speak. We need to delegate to our audit committee the approval of the historic now Mid and South Essex Integrated Care Board annual report and accounts for 2025-26. Assume you're happy with that, because if not, we shall be immediately non-compliant with what we have to be compliant with. And it goes without saying that the other previous 5 ICBs, other than Mid and South Essex ICB, will be engaging in the same way to make sure every aspect of what was there before is covered and signed off properly. Yeah. Thank you. Anyone got any? We're coming to the end of our part 1 of our meeting. Anyone got any comments about the meeting we've had today? Things you'd like to see more of, less of? Yes, please, Rob.
Yeah, I hesitate to mention this because I've not really thought it through. It's just coming to my head quickly. But I did mention it actually on April the 1st as well. So I just think this is I'm going to raise something which could potentially be knocked down as no discussion at all, or potentially quite a significant large agenda item for a future meeting. It's bringing to life what we keep talking about prevention. I'm just kind of thinking whether we need to have some kind of at least awareness or give some exposure to children's and younger people. I'm just thinking, there's kind of children's mental health, there's children's weight management, there's whole area of kind of substance misuse, there's the healthy eating, there's a whole agenda which, the focus has tended to be, because the government's drive has always kind of been looking through a little bit of the lens from the acute hospital perspective, that even in my world as a DAS, I tend to think of prevention trying to stop older people or aging people from having their kind of falls and things like this. I just think that, the prevention agenda is really young people, because if we can get nail them, get better outcomes for them younger, then hopefully it goes through the life course. I'm just wondering whether we need to give some kind of acknowledgement and recognition in a discussion in the future as to how we're measuring that kind of performance of younger people's lives and outcomes. Or tell them to shut up.
Yes.
No, I mean, people were nodding as you were speaking.
Yeah.
So, we'll take it away and work out how best to embody that in our sort of sequence of meetings, whether it's in a strategy discussion or where we come on it. But the points are well made. Thank you. Any other contributions to what we should be doing more of? Less of? No. Thank you very much.